Hi, I'm Adrian Marroquin. I'm the President and Clinical Director at Pand Health, and this is the Might Exposed. I am here with Lila Galustian, LMFT. Thank you for coming.
Thank you for having me. It's a pleasure.
We have known each other for quite a while.
Yes, we have.
I think the world of you,
I
and
love
I'm
you
so
so.
happy that we're doing this together. We're going to be talking about borderline personality disorder. We'll, truncate it to BPD because borderline personality disorder is such a long mouthful.
Such a long mouthful.
Yeah, so we'll just go with BPD. But one of the things that I remember when we first met, when we were working together, was sort of I had always been interested in working with psychosis, and you sort of brought me into the BPD world, and I learned so much about the population and how much I really enjoyed working with the population. And I also saw a lot of overlap in some of the way the symptoms come up. And I was like, who better to explore that with than you?
Thank you. I want to say it's been such a pleasure working with you in this industry. And I love, because in the beginning, you really were like, I want psychosis. I want to go into psychosis. And I was like, trust me, you'll get that here too.
Right.
Because with BPD, it's actually a lot more common than
Right.
people realize, hence why they get diagnosed bipolar
Right.
so often
So often.
instead of borderline personality disorder, BPD. So let's talk about it. What do you want to talk about?
I mean, I guess my first thought is like, how did people separate the two? Like, at what point did people go like, oh, this isn't schizophrenia? Because that's often from what I remember, there were just a lot of people with schizophrenia, diagnosed with schizophrenia, who weren't getting better, and it was often, a particular subset of people, and
Yeah.
usually women. Right?
Yes, it's actually a lot more common in women. To help kind of explain, I think I'll kind of, not to be insulting in any way, but dumb it down and explain borderline personality disorder in a way of borderline personality disorder is it's a personality disorder in a sense. So it comes from two aspects. So there's this heightened emotional reactivity, and more often you can see that from early childhood, early development, where this child is just, their emotions are so loud and their tantrums are so loud and their behaviors are so abrupt and intense, right? And then as the environment is trying to navigate and kind of discipline and raise and help this very emotional child, there's a lot of invalidation that tends to happen. And if there's chronic invalidation on top of this high emotional reactivity, the brain, smartest and dumbest organ when it's developing, it's creating these coping mechanisms like high impulsivity, which is finding short-term fixes. They start having these fears of being alone, fear of abandonment, fear of being left alone. They start experiencing, like they talk about being lonely very often. They go into anger outbursts. Anger outbursts are a common thing. And then one of the things that goes into it is high stress related paranoia. So the difference with psychosis in other diagnoses in psychosis, even with bipolar versus borderline personality disorder, is they will experience paranoia and psychotic episodes in psychosis in a sense when they're in this heightened stress.
Right.
So it's this very, very stressful event that causes these psychotic episodes. And then after a couple of days, they calm down and it kind of passes and it happens again, maybe if another stressful episode happens. And I think that's kind of where it makes it so hard for so many clinicians, right? Because when someone comes into the office and they're like, I'm very paranoid and I'm hearing things and I'm thinking things. And a lot of times when I work with patients that are experiencing that, I have to first off validate and really help them understand, like, that's with, okay, let's talk about the stressful event.
Right.
Let's talk about the emotion. And then let me tell you why it's so normal that you're starting to get paranoid about it.
Right.
Right. And versus a lot of times family members panic. The panic goes to, then they go to a psychiatrist or they go to an MD and then they get prescribed psychotic medication,
Right.
which with borderline personality disorder,
Doesn't really work.
that's not really effective. Having them on psychotic medication just creates more side effects for them.
Right.
It creates more problems, actually, more emotion dysregulation, which then amplifies their BPD symptoms a lot more.
Right.
So I don't know if I answered your question because I always go on tangents. You know me.
I mean, honestly, I'm just thinking like, because I think about like the way that you describe it, I can't imagine people confusing the two.
Yeah.
Right? Like they seem so distinctly different, right? Like where they come from, right? Because with psychosis, it really is like a brain thing.
Yeah.
Right? Like even just thinking about, when someone is saying, oh, I hear voices, the part of their brain that deals with receiving information, auditory information, actually lights up, right? When they're doing like these MRIs or the fMRIs. And it's so different, right? You're talking about this like this thing that is so like brain focused. And then there's this other part of, well, obviously the brain is involved, right? There's the reactivity component, but there's also this significant social piece of the invalidation, which is, yes, our folks totally get invalidated because you're not, Jesus or the next Messiah.
Yeah.
You're not the president of a Fortune 500 company. You don't have billions of dollars. That definitely does come up. But it's very different, right? And how, our folks typically just like water off a duck's back slides off because they're like, they don't take in new information. They're so convinced that it's real.
Yeah.
I wonder if is that similar with the BPD population?
So with BPD population, what kind of it makes it hard is their paranoia can be true. It can, in a sense, like if they're sitting in a room talking to a therapist that doesn't know anything about their personal life, doesn't know anything about what's going on, and the example I'll use is like with personality disorder, there's interpersonal problems consistently, right? Because there's this heightened emotional reactivity and lack of regulation and lack of communication skills, right? So they tend to end relationships, and relationships tend to end with them very often.
Right.
So imagine a young woman in her 20s going to a party where her ex-best friend is at that party, where it ended so traumatically for her, right? And the anxiety of going to that party and being in that party and seeing this person goes from 0 to 10. And 10, the way I explain it for people, emotional intensity at 8, 9, and 10 is going into fight, flight, and freeze, right? That is like when our emotional intensity goes to 8, 9, and 10, that is a communication from our emotions to our brain that we are going to fight, flight, and freeze, which means that is taking this person to now a paranoid psychotic episode, right? Because now they're standing there and they're like, everyone in the room is talking about me. I can hear it. I can hear the whispers of everyone in the room talking about me. So you go into a therapist's office and you talk to a therapist or a psychologist and a psychiatrist that has heard your BPD symptoms this whole entire time. And their first assumption is probably everyone in the room has been talking about you. What did you do that everyone in the room is talking about you? When if you actually take a step back and you ask more questions, no one was talking about them.
Right.
No one even cared they were there. Maybe the only person that cared was the ex-best friend that was across the room feeling very uncomfortable, right? But that person comes into an office and is like, everyone is talking about me. So the therapist goes back to trying to treat the interpersonal skills or lack of skill set instead of kind of pulling back and saying, how anxious were you? What is the evidence behind what did you hear? Give me the facts of the situation, right? So it's actually, unfortunately, questions don't get asked to really understand that there's paranoia happening because of heightened emotion, which I love that you are able to distinguish and help say the difference. With PPD and it's emotional, right? It's the emotional response that sends the brain to wanting to cope and protect and save and fix. versus with psychosis and schizophrenia, it's a brain dysfunction, right? And I don't know if I'm using the correct word, but there's something with the brain that isn't communicating well.
Right.
This side, the brain's communicating. The
Right.
brain's communicating, survive.
Right. Yeah. I mean, because I even just the approach of like asking more questions about the situation and like what were the facts isn't necessarily as helpful with our folks, because you can provide as much facts as possible. It's that bias against disconfirmatory evidence, the idea that no matter how much evidence I give you that contradicts your delusion, you're not going to take that in because you're very convinced that what you experience is correct and is right. And it is like, it's sort of why, you know, CBT, classical CBT, the way that we view it as like, if you change just the way you think, you eventually will change the way you feel and you'll behave very differently. Doesn't work for our folks.
No.
Because you can't change a delusion.
Yes.
Right? In the same way that for BPD, you can work with that thought of everyone is talking about me.
Yes.
Right.
And you can use the old school techniques of CBT, and it really does actually, like when we talk about that triangle where your thoughts play a role in your emotions and they play a role in the way you behave. With BPD, it works.
Yeah.
It works. And if the patient sitting in front of you is willing to challenge their thoughts and not kind of give in to like, I believe it, so it has to be true. Versus with someone struggling with schizophrenia, it's I believe it, it has to be true. But the belief system is more concrete in them. Versus with BPD, they're like, I believe it, it has to be true, because they don't want to face the shame of it not being true.
Right.
Right? Because they feel shame of, oh shit, like I'm starting to realize it's not really that true because my emotional intensity is starting to come down and evidence is really starting to actually pour in, and I'm not in fight, flight, and freeze anymore, so the evidence can come in, versus with schizophrenia, the evidence can't go in.
Right. Yeah, it's a totally different mechanism in how they're responding. You'd mentioned something that because with our population, we talked about like antipsychotics, which is obviously that it can be helpful, but it's not the only thing that helps manage symptoms, right? We talk about like CBT or CBTP for us, CBT for psychosis, which is again, it takes the classical version, and instead of trying to change the delusion, you're changing those downstream thoughts, right? But I know that sometimes it can be really difficult to change things, and in particular with the BPD population, you can't just change all the time.
No.
Right?
No.
What is sort of maybe what was missing? Because I think even for our folks, like that was also missing. There's something missing. You can't just keep trying to tell them to change everything.
Yeah. So that's where Marsha Linehan comes in. Right. Marsha Linehan is the creator of dialectical behavioral therapy. And the joke I make and the way that I try to explain it to people, she's the grandmother that a lot of people didn't have, that a lot of emotional kids didn't have.
Right.
And this grandmother came in and said, your mom and dad keep saying change and change, but I'm going to validate you a little bit more. And then I'm going to give you basic techniques. Like when you're angry, stop.
Right.
Just stop. And when you're feeling really sad, go watch a funny TV show. Or when you're really, really anxious, instead of smoking a vape, take a deep breath. Just a simple breath instead of putting a nicotine inside your body, right? So it's the way I describe Marsha Linehan is really the grandmother that you really wanted your whole entire life to help you regulate your emotions. And she was a cognitive behavioral therapist because she really wanted to work with suicidality and people with acute suicidal gestures. And she tried CBT, and it was very invalidating because it really, when someone is that emotional, there's aspects of emotions that are very valid. There are aspects of emotions, like emotions are what sends signals to our brain on how to protect ourselves, how to take care of ourselves, how to socialize with other people, right? The emotions are the signals we need.
Yeah, there's a purpose for emotion.
Right? That's why all animals have it, and we also have it, and it gets developed, and we have all these emotions for survival reasons. It's just when you are a very emotional person, you are now taking it from like, oh, I need anger to protect myself and communicate boundaries, to I need anger to protect myself. And so Marsha Linehan created dialectical behavioral therapy, which is finding the balance of accepting emotions, accepting the way we are, accepting the biology of your heightened reactivity, while also challenging and pushing you to change the way you think, change the response you have to those emotions, change coping mechanisms that your really amazing brain has created for you for survival reasons. And it's the dialectic of those two truths can coexist at the same time.
Right.
You can be validated and be pushed to change at the same time. And DBT, really, I am a lover of DBT and CBT. I kind of say CBT is the grandfather and DBT is the grandmother, because DBT is simple skills that have been used for a very long time, like take a cold shower.
Right. Yeah. I mean, people do that already in like Scandinavia, right? They go into their saunas and then they jump straight into an ice plunge.
And it works.
Right.
And it's and now we pay millions of dollars for it.
Right.
But really all you have to do is get a big bowl of ice and put water in it and
Right.
put your head in it. Or one of the techniques I tell my patients all the time, walk into Ralph's and put your head in the freezer section. And you're good to go. Take 10 breaths and you're regulated. But she used these old school techniques. She implemented these old school techniques plus mindfulness, plus cognitive behavioral therapy techniques, and created something that works with those dealing with borderline personality disorder.
It's interesting because I listened to you describe DBT, and I think about how when I was learning about, working with psychosis, a lot of people are like, you can't do things like DBT because, people with psychosis don't have insight. Right? It's like this concept that like when you have someone who doesn't know that they're sick, how are they going to change? And I'm thinking about that because I'm like, but their people aren't where they want to be most of the time. Even if they're like, I'm the president of a Fortune 500 company, I'm a billionaire. It's like, okay, great. And are you living the life that you want? They're like, no, because, my family's getting in the way. They won't let me go to the bank to get my money. It's like, so how do we get there? Right. And it's like, those are the things that I think we can work with, because that we can validate comfortably.
Yes.
It's really frustrating to not be able to go to the bank when you want to get your billions of dollars.
Yes.
Right. Versus what people are afraid of, which was validating the, yes, you are a billionaire. Yes, you are the president of a Fortune 500, because you don't want to collude with a delusion.
Yeah. Which I love. And this is the part where I'll say with BPD, it's a little like, that's the part where you don't validate, right? And this is where it really, you can tell the difference, and providers, I hope, can kind of take this and implement that difference. With schizophrenia, you want to meet them where they're at in that situation, and you want to say, yeah, you are a billionaire. You have billions in the bank account, but you don't know how to get to your billions yet. So let me help you get there, right? And that gets them in. But with borderline personality disorder, you kind of want to somewhat invalidate their experience on that. And with invalidation, it's one of the things that when I do trainings on this, I tell people invalidation is a form of validation if you do it correctly, and if you do it non-judgmentally, and if you do it with really a lot of psychoeducation.
Right.
So when someone comes to me and they're like, the whole entire room was whispering, I heard the things they said about me. I heard them saying X, Y, and Z about me. In that moment, it's like, I'm going to stop you. And my invalidation, or DBT invalidation, comes with irreverence. So it comes in a joke-like manner, so it doesn't feel like the invalidation that they grew up with. But it's like, so the whole entire room, everybody, the waiters, the staff outside, everybody was talking about you. Everybody. You are that special that everyone knew the story between you and your best friend. And that kind of invalidation really gets them, although it hurts. Invalidation is very hurtful, no matter if you have a mental disorder or not, right? And you are still going to feel that hurt. And with BPD, they're emotional, so they feel the hurt really intensely. But it does feel like a slap it back into reality a little bit for them. And that's why it's so validating, because they'll be like, okay, no, the waiters didn't know about it. I'm like, well, now that your sass came out, let's try this one more time. Let's talk about the anxiety you felt. Let's talk about, like, it's normal. It's normal for your brain to go into, and then you go into psychoeducation, which is so much more validating for them. Versus schizophrenia, psychoeducation is invalidation.
Right. Yeah, and I can imagine some being like, you're not a billionaire. You and I grew up in a very poor household, and we, have nothing. It's like invalidating. My parent doesn't understand me, and why would they lie to me? Right? Like, why are they trying to, like,
sabotage me?
Yeah. And so I think, there is a distinct difference there.
Yeah.
For sure.
Versus, and with BPD parents, like, when that person goes home and they tell their parents get protective. Their parents get reactive. Their parents are like, well, you don't ever have to see them ever again, and you should never go to a party. And it's kind of enabling that heightened emotional reactivity and psychosis. But then on the other end, what really sucks is that's kind of why a lot of times they get diagnosed bipolar.
Right.
And so then the secondhand invalidation that kind of comes through sometimes with the logical parents, not the, like, emotionally attuned parents, the more logical parents, is like, well, do you think that's your psychosis from your bipolar? And so then now it kind of, a different diagnosis becomes the problem inside of them. And the medication for that diagnosis also isn't working.
Right. I mean, 'cause medication doesn't really treat
BPD. No, BPD is not med-based. Medication, if anything, really, really, really good psychiatrists that work with BPD might prescribe, like, gabapentin to help regulate a little bit of emotion. But CBT, DBT, mindfulness-based treatments, and putting in work to really learn your emotion, to control your behavioral patterns, that's the treatment. And that treatment actually has high success rates. Medication causes more problems, creates more psychosis, actually, and it creates more self-esteem issues. It just amplifies the symptoms so much more.
Yeah. It can be difficult to, have so many confusing diagnoses, because I know, like, we talked about bipolar 1, but then there's also, like, maybe you have a psychotic disorder, maybe you have, schizophreniform, because it hasn't been longer than 6 months to be schizophrenia, or you have, MDD, major depressive disorder, for the uninformed, plus all these other things. And it's just like, or even, you have a complex PTSD. It's like all of these different labels that are so confusing, right? When people are just trying to find out, what is going on.
Yeah. And it's anything but borderline personality disorder.
Yeah.
It's anything, and it's so many providers are weary of diagnosing borderline personality disorder, because there is, and it's happened so many times where within the first session, a lot of times I'll go through the assessment and I'll say to them, you have borderline personality disorder. And they're like, no, I have complex trauma, bipolar, and schizoaffective. And I'm like, nope. Just borderline personality disorder. Just PTSD could be a part of your experience, but complex trauma, no, not really. You don't meet the criteria for complex trauma. I know your emotional reactivity feels like everything has been traumatic in your life, but no, you have borderline personality disorder. And their response is, I'm not crazy. And I'm like, you do realize, it's actually the one of the only diagnoses that you can fully take off of your medical records. versus addiction goes into remission. MDD goes into remission.
I mean, even with psychosis, you will have it, and you're always like just kind of preparing for your next episode, right? And how do you not have another one? Major depressive disorder, also, remissions. And so, yeah, you're right.
Yeah.
People seem to be really bought into anything but this.
For whatever reason, borderline personality disorder is deemed to be more crazy than sociopathy, than antisocial personality disorder.
Right.
Which for me, I'm like, would you rather me diagnose you antisocial? And they're like, that makes more sense to me. I'm like, so you'd rather be antisocial, a person that has no empathy, no ability to create empathy, and let's be honest, you do have empathy, because you see a cockroach, someone kill a cockroach, and you're like, don't kill the cockroach.
Right,
You're like,
right.
that's empathy.
Yeah. It's like when empathy becomes so strong that it like overwhelms you, right?
Yeah, which
It's completely the complete opposite of antisocial.
social. Yeah. So I think we have about 5 more minutes of time. I always love talking to you. It feels like it goes by fast.
No, I feel like time just like stopped for a moment, because I realized like, oh yeah, we're close to the wrap up soon.
We are getting close to the wrap up soon.
One of the things again, we've worked together for a long time. I learned so much from Lily, quite honestly, and it has really like built a love for our respective populations. And for me, quite honestly, if I can work with someone who has, schizophrenia and BPD, that is like, it's the most fun. I say fun. And
it's fun.
You have to think outside the box. That's one of the things I love about our populations, is that like, yes, there are models and there's, handbooks and everything, but the work comes from being creative with this population.
I love that you use fun, because it really, and BPD and even schizophrenia, I love them so much because they're funny. Right. They have a sarcasm that just, you can enjoy working with them. You can really create a fun environment when you work with BPD, when you work with these diagnoses that seem to be so acute and the rest of the world is so afraid of.
Yeah.
When you actually sit in front of them and you actually work with them, you really see how humans are so beautiful. Mm-hmm. You see the beauty in humanity, and then especially the ones that are really working to create a quality of life for themselves, that they want something different. They just don't know how to achieve that something different. And you end up in the room with them, and then both of you guys are working together. It's creative. Yeah. It's fun. It's and yeah, of course there's like intense and there's chaos and there's all these things, but it's different because the willingness and the love and the care and the want is so different, and the way they show up, it's such a beautiful thing. So I am grateful for working with the population that I do. I love running my skills application groups, which is like DBT and CBT, implementing it and teaching the patients how to implement it.
And to pull back the curtain a little bit, when Lily and I were working together, her skills application group was always full, to the point where people were like, it's okay if there's like 12 people in there, I'll find a seat. It's like, no, unfortunately, you're going to have to do a different group. But Lily's not running that group. It's like, I know, and I'm sorry, but that's how great these groups are.
Thank you. I love them so much. And honestly, they're great because of the patients that are inside of it, that come to those groups. And it's so much fun. And I will say, Pand Health is the only place I refer anyone with psychosis and schizophrenia. It really is, because you guys are the only ones I trust. No offense to anybody else, but you guys really do understand this acute diagnosis that the world is afraid of, that everyone thinks they're untreatable, and you guys do such an amazing job helping these humans and people find their way in life with this really tough thing that exists inside of them. So thank you for the work that you do.
Thank you. I, again, mindful of time, I would love for you, if you have anything you'd like to plug.
Sure. I guess I'll plug in. My Instagram is Lila Galustian LMFT. Rediscovering You is my company that I run, and we specialize in working with BPD and also helping kids that are showing BPD like symptoms, how to navigate. And I think that's about all I have.
Great. Well, thank you so much again for coming, and
Thank you.
thank you all for listening.
Thank you.
Thank you for joining Pand Health's The Mind Exposed. You can watch us on YouTube or listen to us on Spotify or anywhere you get your podcasts. See you next time.